minimal cataracts, even though I do warn them that the glaucoma surgery may precipitate worsening of the cataracts. You could do a combined operation of both the cataract and the glaucoma in people with visually significant cataracts and poor intraocular pressure control or poor compliance with their medication. And then the stage sequential surgery, you're deciding whether to do the glaucoma operation first or the cataract operation first. And I'm sure my colleagues on the panel will do justice to that part of the discussion. Now, cataract surgery only may reduce or eliminate the need for glaucoma medication and improve pressure control. Like I'd mentioned, in people with narrow angle glaucoma or chronic angle closure glaucoma, cataract surgery alone could dramatically bring the pressure down. Now, practitioners, after the patient has cataract surgery, may be able to manage the glaucoma better, either because they can do more thorough assessments, or the patients themselves can carry out other tests with just a little bit of a hindrance. Now, the question is that after trabeculectomy, you now do cataract surgery. You might actually cause the filtration to fail. And if you do the glaucoma surgery first, this could induce posterior synechiae, which might make your cataract surgery more difficult. There are a lot of benefits of doing the cataract surgery before the glaucoma surgery, but like I said, it's not in every situation you want to go that way. I'll reserve most of my talk for phaco-emulsification, which is what I'm really here to talk about. Now, phaco-emulsification surgery has been known to reduce the intraocular pressure by about 17%. In the ocular hypertension treatment study, which I'm sure we all know, it's obviously set out to decide on management of ocular hypertensives. And the fallout from that was they found out that phaco-emulsification drops the intraocular pressure by about 17%, and this is maintained for 3 years or more. So basically what we found from that study is phaco-emulsification surgery has pressure lowering effects. Now, one thing we must not forget is that trabeculectomy has greater pressure lowering effects than phaco. And all types of cataract surgery, including intracapsular cataract surgery, actually have some degree of cataract lowering effect. And a predictive indicator is simply that the higher the initial intraocular pressure, the more likely the reduction. That's in patients who have mainly cataracts. When you're carrying out phaco-emulsification, we have to consider, is it one site or through 2 sites? I have some videos, but unfortunately, I would have problems showing the videos because of the internet communication. One-site phaco-emulsification, essentially, you do a scleral tunnel, and then you use that tunnel to do both your cataract surgery and your glaucoma surgery. It saves time, but because of the extra conjunctival manipulation, it gives you more post-operative inflammation, and there is a longer visual recovery. The 2 sites seem to have become more popular now, and what you usually do is you do a temporal approach for your cataract, and after doing the cataract surgery, you now do your usual glaucoma surgery. One key thing is that when you're doing your cataract surgery, try to avoid touching the conjunctiva, try and make it a clear corneal cataract surgery. Eventually, this gives you less post-operative inflammation than the one-side phaco. And if there is a break in the posterior capsule, I would suggest you do a thorough anterior vitrectomy and do not proceed to carry out the glaucoma operation at that sitting. So when you're doing the cataract surgery first, if there are intraoperative complications like a break in the posterior capsule, you can finish up the cataract operation, do your anterior vitrectomy, but reschedule the glaucoma part of the operation. Also, still talking about the combined surgery, the type of or the severity of glaucoma is also a key consideration. One fact is that if you do a separate operation for cataract and you do a separate operation for glaucoma, they give better results for what they were designed for. So if you do a separate glaucoma and separate cataract operation, you would have better pressure lowering effects and probably a slightly better outcome in vision than if you do combined surgery. Now, that had been the gold standard for some time, but some new considerations which I'll mention is making people think of doing things differently. There are less visits to the operating theater for the individual. It's less expensive, and the patient might prefer this. But a combined cataract and glaucoma surgery gives more intraocular pressure control. Now, in this environment, mostly when we are talking about a combined cataract glaucoma operation, we're talking about cataract surgery and trabeculectomy. So it's either a 6 trabeculectomy or a phaco-trabeculectomy. However, there are many, many other types of glaucoma surgery. Like I said, the phaco and trabeculectomy is the most common, or 6 and trabeculectomy. Now we can do phaco and put a tube in the eye. They both have more intraoperative and postoperative complications than if you do them separately. The new thing now is the introduction of MIGS, minimal invasive glaucoma surgery. And it is said that if you have the competence to do cataract surgery, then adding the proficiency of doing a MIGS is not too difficult, and the learning curve is not that steep. Essentially, you're walking through the same incision, and you can decide to put a stent, you can decide to do a trabectome, do Zen implants, or do a canaloplasty. But essentially, phaco and MIGS have increased the amount of operations people are doing for cataract and glaucoma together. Like I said, I had some videos. This first video was supposed to be a video of a one-site cataract operation where you're going through the scleral tunnel and doing both the cataract and the glaucoma surgery through that tunnel. The other video, which unfortunately I also can't show, is to do a temporal approach phaco-emulsification and then go superiorly and do the trabeculectomy. The third video was to highlight the possibility of doing a MIGS, that's minimal invasive glaucoma surgery. And what essentially it was is you approach the eye from the temporal aspect, you do the minimal invasive surgery of your choice, whether it's the trabectome, whether it's putting in the eye stent, what your choice, you do that. And after doing that process, you now go ahead and do your trabeculectomy. Sorry, you do now go ahead and do your glaucoma, your phaco-emulsification. Now, the disadvantage of doing the combined operation is that there are more intraoperative complications than if you do them sequentially. And you get more post-operative inflammation, especially in the one-site operation. Like I said, vitreous loss contributes to failure of glaucoma surgery, and that's why I suggested that you defer glaucoma surgery if you've had vitreous loss during the cataract part of the operation. Post-operatively, one main thing is that you have a lot of pressure, or you could have pressure spikes. And pressure spikes are more common with patients who have glaucoma. But if you do a combined procedure, this reduces the pressure spikes. Releasable sutures are preferable if one has the skill, and if not, one could easily, it's not a difficult thing to learn, but if one could easily learn that and then do that so that you can also do some post-operative manipulation. The important thing of these operations when you're doing a combined operation is that you are going to induce more inflammation than you may realize. So you need a lot of post-operative anti-inflammatory. And my regime is to give you early steroids during the waking hours for 2 weeks, cut it down to too early for another 2 weeks, and keep the person on steroids for 3 to 4 months. I've actually had a patient who we've had to keep on steroids for about 6 months. The choice of anesthesia is also quite important. The key thing is the surgeon should be comfortable with the choice of the anesthesia and to get the best cooperation you can from the patient, because you don't want the patient looking up and down if, for example, you're just learning to do these techniques. Otherwise, there are some other ways you can actually influence it so the patient doesn't move when you're doing your cataract surgery. So the choice of anesthesia is also important. In conclusion, phaco-emulsification surgery is very important in present-day ophthalmic surgery. Not just cataract surgery, but also it's very important in glaucoma surgery. The fact that one can carry out phaco-emulsification, you can increase your armory to fight glaucoma by actually learning the phaco-MIGS or the phaco-trabeculectomy or tube procedures. So to improve your glaucoma surgery outcome, one of the glaucoma experts has said, if you improve your phaco-emulsification technique, automatically you will improve your glaucoma surgery outcome. So a take-home message is that we should all learn phaco, which will help us be very good cataract surgeons and very good glaucoma surgeons. I'd like to thank you very much for listening.